Welcome. This is Brian Celery with.
Dr. Olla. Nice to meet all of you.
Yeah, it's great to have you, Doc. You've been with the organization, what, for 4 years now?
Been about 4 years, maybe a little longer.
Absolutely. Yeah. So why don't you tell everyone what got you into medicine and to become a psychiatrist?
Well, I think people who go into medicine know that very early that they always have wanted to go into medicine. So, it's just something I always wanted to do. And then when I got, really into it and through medical school, I realized that I really loved psych. I was just always fascinated by all the mental disorders and all the conditions.
Yep.
And that's what I wound up, gravitating towards.
Absolutely. And what, you said you were gravitated towards the psych. What are some of the diagnoses that you love treating? What are those?
I love treating the very difficult conditions like schizophrenia and schizoaffective disorder. They tend to be, they're very serious conditions. They tend to be hard to treat sometimes. I do enjoy the challenge and very much enjoy working with them. But generally speaking, all mental health aspects, dealing with anxiety, depression, other mood disorders, things like that.
And I feel like there's a lot of misinformation out there about schizoaffective disorder, schizophrenia. What has kind of been the key to success for your patients who are diagnosed with schizophrenia?
Well, we've had some great advances. The long-acting injectables have been really a game changer. One thing that you tend to see with schizophrenia is, they take their meds, they'll get better, then they'll feel better, and then they think maybe, oh, I don't have to take the meds anymore. They stop taking the meds, they get very unwell, they wind up in the hospital, back on the meds, feeling better, get off the meds. So it's like a revolving door. When you give a long-acting injectable, there's no option to not take the medication. You give one dose. The medication is in them for a month. It can be up to 3 months. We have medications for psychotic disorders like schizophrenia that, it's almost like a flu shot. You come in once every season, every 3 to 4 months to get a shot. There's no need to take a pill. And, it always delivers a steady dose, the right dose every time. And it really keeps people out of this revolving door situation where they're going back in and out of the hospital. So it really goes.
Absolutely, and I think that's great information for everyone to know. And I've seen a lot of your presentations. You do it for the community, and we always appreciate when you're out there donating your time. And the one thing that you do here is you do groups at Valley Spring, right?
Yes.
And
do groups, yeah.
So for someone coming in, we just launched our mental health program, but someone coming in, whether it's the mental health or the substance abuse, what do you teach them in the groups?
Really, we do predominantly here dual diagnosis. So a lot of the groups are geared towards chemical dependence, but we treat the mood disorder or the anxiety disorder at the same time. So generally speaking, when it comes to substance abuse, I tell all my clients there's a cure for addiction, but it only lasts for a day. You've got to reaffirm this every day. So, that's typically the thing I see when someone's been sober 5, 10, 15, 20, 30 years, and there's a relapse. It's usually the same story. It's, hey, I stopped going to meetings, people, places, and things. I became complacent. I used to be a sponsor. I kind of gave it up. I was a sponsee. I don't talk to my sponsor anymore. They sort of, fall out of the structure of recovery, which in the aftercare involves, going to meetings, being part of a community, whether it's a smart recovery or AA model, to just, be in it and have that reaffirmation every day, that quote unquote cure for addiction. I mean, maybe there, in my opinion, that is the cure.
Absolutely. I think that's great information, and I love what you said, that there is a cure. It only lasts 24 hours. I've never heard it said in all the years. I've never heard someone say it that way. And I think that was amazing the way you said it. And so you do some groups here. You do some education on medication management and
Yes.
post-acute withdrawal symptoms.
Absolutely.
Can you explain to people what pause is?
Sure. Post-acute withdrawal syndrome, very typically, most drugs have a certain withdrawal period, a few days, a few weeks, and, the symptoms of serious withdrawal symptoms begin to subside as the body begins to adapt to not having the substance. But there can be a situation where a person is many days, many weeks, or many months even outside of the typical period of time where there's withdrawal symptoms from the substance. And, it can be very mild symptoms. They can be brain fog, confusion, tiredness, a low energy state. Many times people confuse that with depression. They're not sure what's going on. They feel like they maybe have, a lingering flu or cold that just won't go away. And it's really an emotional problem. It's a post-acute withdrawal syndrome. It's related to the perhaps months and years or extended period of the brain being used to being on the substance and navigating the world while in the presence of, the substance of choice, and now having to learn to navigate the world without it. Mm-hmm. So it can cause a lot of these symptoms. You see many times we have these functional MRI studies where you can see colors lighting up in an MRI, and you see studies of people who have lost their dominant hand, for example, and now have to brush their teeth with a non-dominant hand.
Wow.
The first day you see them, they're poking their face, they really can't get it, and you look at the functional MRI, this thing is lighting up in all areas. So this part of the brain talks to this part of the brain, is talking to this part of the brain to talk to these two parts. It's just colors all over. It's detecting metabolism. Your brain is working overtime on overdrive, trying to navigate the world without your dominant hand, learning a new task. Mm-hmm. Then after a month or two, you see the patient and they're like it's second nature. And you look at the functional MRI, it's not lighting up at all, just maybe a little blip. So suddenly the brain has become extremely efficient at navigating the world with the non-dominant hand. That's in essence what post-acute withdrawal syndrome is. The brain has to become accustomed to navigating the world in a new way now, and it takes time to adapt.
I think that's a great analogy for people to understand, and that's one thing I think you do really well is give real world examples and tie them back to medicine so people can understand the complex medical side of it, but also, someone, your son's age would also be able to understand it, which is always something I appreciated. Now, when
you can also imagine, if your brain is, busy, all different parts of your brain are busy talking to other parts of the brain, of course you're going to be sluggish, your processing speed is going to be slower, you're going to feel like a low energy state, you're going to be tired, easily distracted, so.
Yeah, and that's why I really like what the Health and Wellness Committee has done here is that we focus on really educating them, including yourself, on what pause is, why they're feeling a certain type of way, and how to gain that energy back at a more rapid pace. And that's something that I love that we've done. But patient comes in, paperwork to be done, and then eventually they come to your desk, right? Or one of our other psych providers. What is the mental health assessment like with Dr. Olla? What are you trying to educate them on, and what is that tool used for?
I'm more of I'm less of a diagnostician and more of a formulationist. So, in my clinical practice and in psychiatry, we use the Diagnostic and Statistic Manual, the DSM, and that gives us all the various diagnoses. I find that approach a little bit stifling, and I don't like putting people in boxes, and essentially, those are billing codes that you're looking at. It's a consensus of what we all agree is a billable mental health condition. I'm much more of a formulationist, which is, I like to take the biopsychosocial formulation and really look at that, the biological, psychological, and social aspects that are, present in this, the picture, the whole picture of the patient before me. Psychologically, what is going on, socially, what's going on, who are they surrounding themselves with, who's in the contacts list of their cell phone. That's much more important to me than, perhaps coming up with a diagnosis right away. Because at the end of the day, there are a lot of symptoms, and there are a lot of crossovers with symptoms with various psychiatric conditions. So, my method is more, you're looking at the biopsychosocial formulation and taking a very holistic approach to it,
And you're looking at the whole patient. You're not just looking at the basic symptoms. This is a comprehensive assessment. You're in there hour and a half with them sometimes, right?
Yep.
And really getting to know them on an individual basis. Now, you said that the diagnosis is the symptoms. It could show one thing, but it could actually be something else. So those follow-up psychiatric appointments or med management visits that they have with you weekly, what do you try and get out of those? And, sometimes they're 10 minutes, a quick check-in, and then sometimes they can go up to an hour if there's a lot going on with the patient.
Yeah, absolutely. I mean, there are, definitely cases where people come in and they have their own provider, so there's really not much for me to do with them. Other times they just need, a refill on their medications, and it's a 15-minute visit. Hi, how are you doing? How are you feeling? Everything going okay? How's your sleep? Is that okay? How's your appetite? It's usually just a quick follow-up. And sometimes people are in crisis. And, when that happens, I divert, more time to that particular case. So it really, goes case by case. Sometimes the session may be exclusively psychoeducational. Someone might come in with a question about a medication, and that predominates the session. Sometimes there are, conflicts at home, marital issues, and things like that. And that's really the predominant thing that we talk about in the session. And maybe that session doesn't cover it, and then I have to organize a, like a family meeting, or, sometimes we'll do, myself, a counselor, and a husband and wife together. So it really depends. It goes case by case and according to what the individual needs of the client are,
Absolutely. And when you do see the importance of medication for a patient, do you walk me through the educational piece of how you explain to a patient why they're having a certain medication and why it's important for them to keep? Because I think we both can agree, you were talking about schizophrenia before, where it's this revolving circle, right? Your job is to, change that circle and have them just go in one direction. So how do you explain to them the importance of medications and what the medication will do to them?
Again, it goes case by case. Some people are very, agreeable to taking medications. They see they have a problem, they, looking for solutions. Some people are extremely averse to medications. They don't even want to take an aspirin. So again, it would be very, case by case. One thing I see a lot in my practice is polypharmacy. That means someone coming in on a whole bunch of medications. So what I like to do in a case like that is first review all the medications, look at the interactions between the medications, and try to find out if there are any medications that we can either lower the dose of, or are redundant in some way, or are just not necessary at all. So I'm a big fan of less is more when it comes to pharmacology. I also don't like adjusting more than one thing at a time. When you see too many medications at once, you really don't know what's doing what. And then if you add another, if you get a side effect, you're not sure which medication is causing the side effect, then you've got a problem. These things all interact with each other. Many of them go through the same organs to be metabolized. And, I really like to do a thorough review of the medications and first even see if all the medications they're on are appropriate for them. A lot of times they're not. Absolutely.
And, there's sometimes where can a medication actually stop working for a patient?
Oh, yes. It happens a lot. You see it a lot with the antidepressant, anti-anxiety medications, the SSRIs and things like that. Typically, a patient will say, hey, I was on maybe Prozac or something for a couple of years. It was great. It really helped. And then I just, notice it's not working anymore. So, that's a typical thing. There's different ways to deal with it. Some medications you can take a little holiday from and then come back to them, and then they start working better. Sometimes you might need to switch a medication. If it's the case that we need to switch a medication, I do it very cautiously. Oftentimes I'll do a cross taper. I don't stop one medication and start another. These medications have certain half-lives, so they leave your body at different rates. So, something maybe like Paxil, you would not want to stop that abruptly because the blood level would drop quickly and you can kind of get this crashing effect. So, many times what you want to do is you want to cross taper something. So introduce a new medication at, a very low dose and begin to decrease the other medication as I begin to increase the new medication until the other one sort of, falls off. And that's how I would switch them to a new medication if we needed to. And then there are other treatment modalities where we can add another medication to the antidepressant to sort of turbocharge it, really kick it on a little bit stronger. That's another method that I can use to do that.
And, I think we've, just talking about one more medication, then I want to talk about our mental health program. But, I was always, my first job in behavioral health was in admissions. And there was a lot of clinical background that we were taught. And, ketamine, anytime we heard the word ketamine,
oh, yes.
we knew what that was, right? And that was one of the questions we asked now it's being used to treat, what is ketamine being used to treat for, and who would benefit from that?
It's actually, as it turns out, excellent for refractory depression. Refractory means, you've tried multiple medications and treatment modalities and they have been unsuccessful. So in that particular case, ketamine would be an option, and it seems to have a very rapidly reversing, it's able to rapidly reverse suicidality, which is obviously very useful, So, you can get it in an infusion. So we would refer someone to a ketamine clinic and they would go in for an IV infusion at, a couple times over the course of, several weeks. Or there is another method where it's a nasal spray. We go to the house or to the client's place of residence and give them a spray in each nostril, observe them for 45 minutes to make sure everything's okay. Then we leave and come back in a few days and try it again. And, we do that for a few weeks. And you see, a lot of very good results with it. I mean, it's a very, very good option for a lot of people.
It's just amazing how much medications are recycled, which is something that I learned from you.
Absolutely.
During your presentation, how in the 70s, 80s, it was used for one thing. Now it's used for
all the time
psychiatric diagnoses. But, you talked about suicidality, right?
Yes.
I think people struggle, what's the difference between a suicide attempt and a suicide ideology?
Well, suicidal ideations can come in different, I would say they're on a spectrum, right? There's that feeling of, I wouldn't want to kill myself, but I'm ready to give up. I just don't want to live anymore. I wouldn't care if I disappeared. Those are sort of passive suicidal ideations without any intent or plan. They are on a spectrum. Then, to the more serious end would be a suicidal ideation with intent or with a serious consideration to carry out such an act. That would, that would be on the more serious side of the spectrum. I mean, they're all serious, but that's the more dangerous side of the spectrum. And then when it comes to that dangerous side of the spectrum, there's a suicide rehearsal. That would be the most dangerous thing. That means, I have rehearsed this. I've hung the rope. I know it can hold my weight. I've rented a hotel room. I'm making plans, So there's suicidal ideation with a plan, suicidal ideation with rehearsal. So it really is a very, broad spectrum.
And that's, I didn't even know about the suicide rehearsal. That's great information. And, in regards to a parent or a loved one who's, child, husband, wife, whatever it may be, has had anywhere on the spectrum, what would your advice be to them to give them hope?
Well, definitely, would be time to talk to a doctor, that's for sure. I mean, there is help out there. And, this is a problem that millions of Americans have, millions of people. There is help. Lots of suicide survivors, people that have attempted suicide and been unsuccessful, it's good to hear some of their stories, because they got help, and most all of them will tell you, hey, I can't believe I was in that place. This is, definitely don't do it. There's help out there. There's lots of terrible stories out there that I've heard, but there is help. There are medications. There are many treatment modalities. And, this is a very common problem, that people have.
Doc, do you believe underlying mental health leads to substance use disorders?
Yes, absolutely. At the end of the day, what many addictions boil down to is self-medicating pain. It doesn't have to be physical pain. Of course, that's how a lot of opioid addicts get started. They have a back issue, they start taking tablet opioids that are prescribed, and that starts the ball rolling. But it doesn't have to be extreme physical pain. It could be just a toxic work environment, a bad relationship, a difficult boss, emotional pain. When you begin to self-medicate with a substance to cure your emotional pain, you definitely get into addiction. That's exactly how it starts.
Hey, what's going on, guys? I'm Paul. I am the content creator here at Valley Spring Recovery Center. I'm also an alumni of the program. And I don't know, me and my former counselor, Zach, we were talking last night about the use of Topamax to treat cocaine cravings. And I was just curious about the fact that it's not used originally, to curb those cravings. So.
Yeah, I talk about this a lot in some of my presentations, how medications are often repurposed and rebranded. I always give the example of Rogaine, that most people are familiar with. Minoxidil is actually a blood pressure medication, and we found out that when we gave it to people, they got really hairy. So we just decided to put it in another bottle and say, now this is hair tonic. That's the way things work. I mean, we find out a side effect, and then sometimes we exploit that side effect. Like, a lot of our non-addictive, non-habit-forming sleep medications are that way. Trazodone is a famous one that started off as an antidepressant, but they just found out it made people go to sleep. So they market it as a sleep aid. So the same thing with Topamax. Topamax is a multi-purpose medication. It's wonderful for migraines. It could be used, in the context of epilepsy. It can prevent seizures. It can be used as an appetite suppressant. And we found out for some reason, having to do with certain receptors, that it interferes with cocaine cravings, which is really good, because there's not a lot of medications out there for cocaine cravings, and there are no FDA-approved medications to treat cocaine cravings. But Topamax or topiramate is actually very effective, and sometimes they can combine it with other medications also that have the same type of anti-craving effect. So we like to do a lot of off-label treatments. Whatever works, if we can find something that works safely, I'll do it.
And what could be used for alcohol cravings?
We have a number of medications. I mean, the standard medication we use is naltrexone. That will curb alcohol cravings, but it can also be used for opioid cravings as well, and that comes in a tablet. We also have Camprol, which is another medication for alcohol cravings. It comes in a tablet. And then, similar to what I was talking about the schizophrenia with the revolving door, I mean, there's a similar kind of thing that happens with alcohol dependence also. It's sort of like, there's a very psychological component to relapsing, and maybe if it's Thanksgiving or New Year's or a holiday or something, a person will say, I kind of want to drink tonight, I'm not going to take my tablet. With the long-acting formulation, we give them an injection of naltrexone, that's the anti-craving medication, and it delivers all month long. So there's no option to not take it, it's in you.
Something else we don't talk a lot about is gambling cravings, right? We live
Yes.
in a society where gambling is on your phone, and I know football Sundays, I
Yeah.
can't wait to bet my $10 and whatever the teaser is,
Right.
and football is going away this weekend, and so I could feel it a little bit. But as far as gambling cravings, is there anything that you can prescribe someone?
Well, the medication I just talked about, naltrexone, would be very good for that. There's a very intimate involvement with dopamine, and dopamine is central to all the addictions. So, if you can imagine yourself, a lot of times people can't understand how a porn addiction or a gambling addiction works. It's not a pharmacological addiction. But if you can for a moment picture yourself as a 16th century European peasant, and your diet consists exclusively of boiled mutton and boiled chicken, and you've never had any salt in your life, and that's just all you've ever known is boiled mutton with no spices and no salt. And then someone comes along one day and says, hey, I've got this stuff here, sprinkle a little of this crystal stuff on your food, and let me know what you think. Suddenly, the mind is blown, right? You can never, ever have mutton again without salt. And in the old days, that's where the salary comes from, right? If you're worth your weight in salt, right? This is where this comes from. People would kill each other for salt. We had, spice trades and salt, war over salt and things like that. And gambling addiction is the same way. As soon as they hear the jingling of the slot machines or the change hitting, it turns on a dopaminergic pathway. It's the same type of thing as, with the mutton. There's a dopamine surge that's involved. So the medication, the same way it works for the pharmacological addictions, it will sit on the receptor and do its job and essentially blunt the gambling craving the way it would blunt an alcohol craving. It has the same type of effect.
Yeah.
And work for the same thing with porn addiction also.
You open talking about Valley Spring being a dual diagnosis program, right? We have our substance use license, our mental health license. Now, we've always spoken as a staff that 70% of our patients are co-occurring, leading substance use, secondary mental health, and then, towards the tail end of their stay, it's almost we're more treating the mental health, and that's why we went out and we got the mental health license. But would you agree or disagree that the majority of substance use disorders do start with an underlying mental health condition?
I think that's probably true. Yes, because at the end of the day, for many people, an addiction is it's really self-medicating pain. Our clients that are out there, shooting 50 bags of heroin a day, or, I have one client that, stands on her head in the morning in front of a mirror to engorge her neck vein to inject upside down. At that point, we're not talking about a habit anymore. This is a serious illness. It's a disease at that point.